Hi, thank you. Yeah, not doctor yet. I have another month. But hi, everyone. Thanks so much for coming today. My name's Chris. I'm a medical student at the University of Michigan, and today going to be presenting an implementation science project that we did on laparoscopic skills in Liberia. So just press this here. So this project was supported by a SAGES medical student grant and the Global Surgical Training Challenge. So our project takes place in Liberia, which is a country of approximately 5 million people, and is well known for being the epicenter of the West African Ebola outbreak from 2014 to 2016. The country's really struggled to build surgical capacity, especially with a shortage of providers, particularly located in urban areas. Despite all the advantages that laparoscopic surgery could have in a location like this, there was really no understanding of the availability of these operations. And so our team started by conducting just an assessment of laparoscopic availability. We had the majority of the providers in the country answer our questionnaire and found essentially very low levels of experience, including that only 3 operations had ever been performed laparoscopically in the country. Despite that, there was huge desire to participate and get training. We also found that there was a huge shortage of expert faculty, which would be a key barrier to actually implementing a program. And so I've had the privilege at the University of Michigan to be part of the All Safe team, which was a program that was founded exactly to combat this barrier of training. It was founded in response to the dearth of laparoscopic opportunities for LMIC surgeons and aims to create an accessible and low-cost training platform for surgeon learners in these contexts. As you can see from the diagram here, it uses a cardboard box with a smartphone and a laptop in order to step a learner through both cognitive and psychomotor portions of performing a laparoscopic operation. We have 6 different modules now, including common operations like lap appy and ectopic pregnancy. And so whenever you're doing an implementation science project, it's important to make sure that the intervention, the thing you're actually implementing, is going to do what it's intended to do. And so for the last 2 or 3 years, our team has been building evidence around the validity showing that all safe use actually improves both cognitive and psychomotor skills when you're using the program. Despite that really exciting evidence, we haven't yet scaled or implemented this program in novel contexts. And so that was the aim of this study, really using Liberia as an exciting opportunity to collaborate with our partners. So we wanted to evaluate implementation strategies for all safe uptake at 3 Liberian hospitals. And we did so by selecting 5 strategies from the expert recommendations for implementing change protocol. This is a project of a list of over 70 implementation strategies, which outline different ways to successfully implement interventions. And by meeting with our team, we decided that 5 would be reasonable to put into a bundle for this context. The first is program orientation, which is a person sitting through, guiding someone through using the All Safe program, learning how to use it. Local champions, which include appointing basically site directors to motivate and encourage others to use the program. Network weaving, or establishing a WhatsApp group where different users across the hospitals could communicate with and encourage each other. Feedback mechanisms, which for us was a weekly surgical meeting, giving people audit and feedback on how they were doing. And then practical supervision, which is by far the most time and cost intense strategy, but involved having a person there at the hospital at all times to encourage people to use the program. So we implemented this program last year over a month. The first site was JFK Medical Center. This was the largest hospital in the country, the only residency program, and a major urban teaching hospital. And there we implemented all 5 strategies. Our second site was Phoebe Hospital, which was quite different. It's a rural referral hospital, and there we also implemented all 5 strategies. Our final site was Elwa Hospital, which is also in the urban capital of Monrovia, but is a missionary hospital. So it sort of sits between the extremes of rural Phoebe and very well-resourced JFK. And there we only implemented a partial bundle. And this was done to see if there were any significant differences when we did and didn't have this very time and costly strategy of supervision. And we used a mixed methods evaluation to analyze uptake. So in terms of our results, we had 28 participants across all 3 hospitals, over 75 training hours, and 4 participants were able to actually complete full modules, which were laparoscopic appendectomy. Looking specifically at each site, we found that JFK had the highest level of quantitative engagement, both in terms of total hours and median participation hours, but that Phoebe and Elwa were had more eligible participants who actually completed the program. We did find that when comparing sites with and without supervision, there was a difference of times that was very close to but not reaching statistical significance. Importantly, we found that our engagement decreased with time. As you can see, there was huge excitement for the program in the beginning, but gradually that tapered throughout the study period. As I said, we conducted end user interviews with 8 participants, including 4 local champions, and found 3 major themes. The first was that these 5 strategies were considered acceptable and feasible by our cohort. Second, that practical supervision, including technical support that came from it, was very important to participants. Even participants at ELWA who didn't have the practical supervision say they wish that they had. And finally, the importance of clinical translation. So understanding how the work that they're doing in this box, practicing those skills, would actually lead to real patient care. Here are some representative quotes. For the sake of time, I won't read them all, so feel free to snap a photo if you'd like to review them. But I will go through the last one because I think this really emphasizes the importance of the clinical translation. AllSafe is great. The idea is brilliant. One challenge is that the idea may not go anywhere. When trainers leave, participants may doubt how we are going to translate these skills into an actual patient. Help them to see that it can be practical. So in conclusion, these 5 validated low-cost implementation strategies were considered both feasible and acceptable by our cohort. The hospital context likely had a big influence on AllSafe uptake, and we had both quantitative and qualitative data to show the importance of this, though time-intensive, important strategy of practical supervision. And as you all saw, there was a clear need for additional strategies to improve sustainability to make sure that people continue using the program. Finally, and most importantly, I'd just like to acknowledge our team, particularly our Liberian colleagues. These include Dr. Cassell and Dr. Mabanza at JFK and Dr. Limfuka at Elwha Hospital, as well as the entire JFK surgery department. And then to our AllSafe lead team, Dr. Jeff Coach, Dr. Kim, and Dr. Rooney. I left my email here in case anyone would like to connect, and thank you all so much. I'm happy to take any questions.